Welcome to the Long-Term Care Chronicles podcast.
So I just want to say thank you so much, Micheal Limerick, for coming on to the Long-Term Care Chronicles. And before we start, if I can just get you just to further indicate your role as well as what is it that you're doing at this particular moment. Thank you.
Thank you so much. It's an honor to be a part of this. I never thought in my career that I would be doing this. When I first started in long-term care in 2016, I thought, what a great opportunity to learn about end of life and chronic care management. And it's something actually that I've had to become an advocate for, which I wasn't prepared for, but that just tells us sort of the state of affairs in our country and in our province. But I've been a nurse practitioner since 2008, so for 13 years now. Most of my career has been in an emergency department at a tertiary care center in Winnipeg, Manitoba. Moved to rural Ontario, Kenora, about 5 years ago. And there was many different NP positions at that time. For me in long-term care, it seemed like the least amount of probably what would be most familiar to me from working in a hospital to working in a long-term care facility in terms of I should say, and I use air quotations, the business of healthcare in terms of seeing people and being surrounded by a team and working in that environment. So I said, this is something that I'll try and just see what happens. So now I'm hooked. In Kenora, I'm in two different facilities in Pinecrest 3 days a week and Birchwood 2 days a week. And of course, COVID has confused and made all of that complicated. And then my other big part of my role is sitting on the Palliative Care Committee, Regional Palliative Care Committee, and then advocating for hospice that we were able to implement and start last year, which we are the first of our kind to operate that and run that in long-term care. So I'm doing 100% long-term care and hospice care. And then my role is probably equally as an advocate in this area.
For sure. Thank you so much for that. And so if I can get you to just define what is palliative care and end of life, as both these two terms are used pretty much interchangeably, although they mean different things.
Yeah, I get that question a lot, and I'm perplexed on why it's complicated, but I guess because of the environment that I'm in now and how we use that language and meeting people and families at this time, it is always a new experience for people. So, palliative care is basically a continuation or a continuum of care to try to increase quality of life and help people live as best they can, depending on their terminal illness or diagnosis. So at that time where, our main focus is on symptom management and, there's still an aspect of palliative care that is still curable care, or things that we could possibly fix or change or alter in terms of things that happen with end-stage disease management or symptomatic acute management if there was an infection. So it's about, if you're involved or if you become within palliative care, technically, or in a perfect world, you're followed by a team, and that looks after many aspects of the different types of things that you require, even including spiritual care and psychosocial care. When things are changing on that continuum, and when you look at risk benefit of certain treatments, and perhaps maybe you're spending more time in bed or more time sleeping, or maybe you're having more time where you're unconscious or not eating as much, then you're approaching end of life. So at that point, our goal is when reversal of certain symptoms or disease management is no longer possible, our goal is to optimize that quality of life at the end and control symptoms as best that we can. Lots of people at that point, are concerned and talking about possibly difficulty breathing or pain and how that's managed. And we focus mostly with that at when people are at end of life. So when someone's palliative, sometimes that can be, we look at the definition of it. Sometimes people have years to live when they have a palliative diagnosis. When someone is deemed at end of life, in some worlds that might mean less than 6 months or less than a month, but usually it's when things are becoming a lot closer.
Okay, thank you so much for that. So just to clarify, so then that would mean, so let's say someone had dementia, that would be considered to be as palliative care or deemed as palliative.
For sure. So a lot of people, when they get diagnosed with congestive heart failure or end stage, or I shouldn't say end stage, I should say, or renal failure or dementia, right? That doesn't mean when people hear the word palliative, they're sort of, well, it would be shocking to hear that. But in terms of it's a disease that is going to continue to progress and continue to change. And at some point, because of how possibly increased disability that you would have, we need to advocate and start talking about those things right away, because dementia is a cause of death. It is a terminal disease and something that's so important that we talk about right at the onset of that to help people prepare for the future.
Thank you. That's great. And so with the family discussions about palliative care and end of life within the long-term care setting, how are these discussions initiated so the families are included and they know what is coming and they know the difference between the two?
So that's a great question. Just recently in my role, as of last week, I was talking to another nursing home in Timmins. And how we found each other, I'm not sure. There's always the RNAO advocates out there that are looking at best practice and trying to connect us with things. But it needs to be incorporated as a part of every long-term care facility's palliative care policy and having those conversations. And it's weird to think about why wouldn't we, or why aren't these conversations happening? And I think just because it's so difficult, it's not easy. And we assume that many people perhaps would take that role, but if it's not formalized, and I think it's probably human nature that, we don't like to talk about death. It's something that we've never been good at, depending on, in terms of the evolution of how medicine has changed and what we've done. People used to die at home. The family used to take care of people at home. That was a normalized thing. As a young child, you would see death. And now we don't talk about it, mostly don't talk about it. I know I'm generalizing. And we don't see death. We're not a part of that process. And for many instances, right, when someone passes away, whether it's in the hospital or it's the home, the body's taken out the back door. It's something that's hush hush or not wanting to be advertised. And really it's something that we need to normalize in this experience. I mean, the average lifespan of people that are admitted to long-term care is 18 months. We've got a lot of work to do to prepare people and families to talk about how we're going to make this experience as best we can for them and to give them a good death in respecting who that person is and all of their values. So we start that conversation right at the admission process. We have an admission coordinator that again talks about advanced care planning and is to, tries to initiate those conversations, which aren't easy. The next thing that we do is formally at the first 3 months of admission, we have our first care conference where there's a lot of information shared there. And sometimes it can be pretty heavy, but at that time, I get a good understanding of someone's illness understanding, whether that's the patient or the family. And then usually after that meeting, in a respectful one-on-one way, whether that's on the phone or in person right now, to gently start to talk about and tease out that information about what are they ready to talk about these issues? Do they understand what the diagnosis means and in terms of what that person might have articulated or said earlier before they came into long-term care, what was important to them in terms of their management and treatment. So it's, again, a process that should be formalized, is formalized, but most often it changes on a regular or on a daily basis, sometimes based on and some families aren't prepared to talk about it, and that's okay. But when there's a change of condition, it's another opportunity to formalize that process again and talk about risk benefit of certain diagnostic tests if we're going to do things like that, or certain treatments. So mostly we need to talk about it all the time. It never stops. And the biggest surprise is when they come into long-term care that they haven't had these conversations before. It hasn't happened in family practice, and it hasn't happened in the hospital. And sometimes they've been at the hospital for 6 to 8 months before they've come to us. So there's lots of things that we think that we could do better and that we're working on in our community. We're also part of this capacity assessment when we're looking at leaning our palliative care processes and communication. But it would be wonderful, especially in rural settings, if providers could go between facilities easily. And I think that it would be benefit if I could leave my place of work and go into the hospital, actually just to have those conversations about preparing for the future and end of life. The psychology is so important for people coming over in their next journey. And it's, I know mostly that we probably downgrade and I'm using air quotations, the care or the level of need that people have as they get older and as they come into long-term care. But actually it's more complex. And it requires a huge team of skilled medical and social care that we struggle with. You know, I know you're going to ask me more questions about this, but it's all around funding and human resources and what we value. And I believe it's getting better. And this is the right time with all the things getting better.
Oh, thank you so much for that. No, that's great. That is very a holistic type of an approach. And then for your for each staff member, that so once somebody is admitted into long-term care, how does now each staff member, what is their process in facilitating for the discussion for, because I know you mentioned about the care conference, that's within the first 3 months. So what would then be the continuum of that conversation by each staff member?
So this is something that I find continues to grow and get better in our facility. But when someone is condition is changing and they're requiring more care and or approaching end of life, the only way that we really can make sure that we're all on board is to meet with the team. And so whether that's a discussion with the PSWs and the RPNs and the RN, and sometimes that's included with family again. But again, in just discussion with the whole team, because of to talk about perhaps expected changes or things to watch for or look for. And in terms of how best that we're going to manage pain, or we're going to manage shortness of breath, or we're going to manage end of life secretions, and what each staff member's role is in regards to that. You know, it's a long-term care has so many people, employs so many people. And sometimes my expectations are when I talk to a different PSW or a different nurse that they've done this before, that, you know, this is our job, this is what we're good at. And some people actually have never, you know, worked with a dying person or helped in that aspect. And sometimes because it's a cultural reason, sometimes it's because they're just not confident or they're nervous. And with such a big facility and so many people, you can avoid those cases if you switch with different people or alter your workload or your shift of who you're looking after. So it's important to, and I was just saying this to the home in Timmins that I was talking to last week, is I often feel like a death doula instead of a nurse practitioner. I find that I'm looking for and trying to push staff to say, who's approaching end of life, whose PPS score has changed, who's not eating, who's pocketing, who's having more pain, who's not sleeping. And then let's get together and talk about how we can de-prescribe, change medications, change our approach, consider again having the family in and talking about changing what we're doing, because it only improves their symptom management and helps them as they're changing. So we all have a a really important role in what we're doing. And I know you're going to ask me questions later about the evolution of that role, but to do it as holistic as possible is what's key, especially when I find treating someone at end of life isn't necessarily that complicated, but the psychosocial aspect of what that family requires and doing that well and helping people is the most complex part of this job, that I find that we all need help in working with each other to know how to say the right things and ask the right questions and support people as they change. It's not easy. It always pushes you to think about your own mortality. And I think that's why healthcare professionals, staff probably want to avoid the conversation. You know, it's not easy, but that's why it requires thoughtful, skilled people in this area to do this type of work.
No, that's great, because I'm really glad that you mentioned about the mental state of some people, like the staff that are working in it, because not everybody is suited or can handle working in this type of, whether it's palliative care, end of life, they can't handle that. So how is it that you're providing the best care and the resources available to a lot of these staff members? And, do they feel supported working in this type of, because it can be overwhelming or a bit depressing, so to speak, but, how do you, and your facility be able to handle that?
Right. So that is a difficult question. It's I think it's a lot of times. So if I just look at the institution or the facility, and I like to use that word. I think the word institution is a dirty word, and that's why I use it all the time, because we're forcing people into institutionalized care based on the resources that we have. It's sort of the best thing that we can do right now, but it's not by far the what's ideal or what's optimal. There's what people require at end of life care. I think, one of the most important things in that role is spiritual care and emotional care and the psychosocial care that is the most difficult that care to provide in terms of, so when you're a PSW and you go to school, what are you being trained to do? When you're an RPN or an RN going to school, what are you trained to do? And then I look at my role in my education doing my nurse practitioner, there was I didn't formally learn any palliative care or have any palliative care rotations. And many of my physician colleagues would have the same type of education. So it's something that we experientially we learn and pick up as we're, depending on the area that we're working in. But to do this role, especially as being a MAID provider and not having the psychosocial support there present for the family when they're dying, and even I say is equally as important for the staff. In this aspect, so I'll tell you a personal story. When I was working in intensive care and in emergency, my role was to prevent death. My role was as part of a code team, and I saw a lot of trauma. And every time that we were involved, or I was involved in a code or a situation where people were dying, we did everything we can to stop that person from dying. I mean, that was our goal, that was our mission. And it was really hard. I had to separate myself and take some time off because of the issues that I had in dealing with that role. I needed some psychosocial support, and I needed to talk to people because it just wasn't normal. The experiences that I saw sort of surrounding that. Coming now and working in palliative care and in long-term care, my wife's the first person to say to me, you got to be really careful. You are in an environment where you were surrounded by lots of death and dying, and that was really difficult. And there were aspects of that I didn't do well and really struggled. But in this case, it is a normal process. and something that we need to support each other through, and is an expected process, which makes it a lot different. But I still see that I need someone at the end of the day to talk about the experiences that I've seen, or some of the cases that I've seen, because you are giving 100% of your energies to make it go as best as possible, and not necessarily in terms of helping a person with symptom management as they're dying, but helping that family cope and understand and know that it's okay, has an impact. So we operate here without social work. I think most long-term care facilities in the province, depending on where you are, don't have spiritual care or don't have social work. And I find that when you are admitting your entire population that has got approximately a lifespan of 18 months, and all of the major changes that they're going to go through and all of the support that they need, I think it is bizarre that this area isn't supported more in that way, when that's such a major and integral part of what we need at this stage of our life, is that psychosocial support. And I think our most important people that could be part of our team is the spiritual care component of that and the social work component of that, even for the staff debrief, even to support people as we're looking after people that are dying. I think we totally overlook that in palliative care, and especially in long-term care. It's just, part of the job, is what maybe your manager would say, or when you were going to school, it's just what we do. But it's not normal to do this every day. And so it's to be supported and to do it well. It's important that we have all of those supports in place for us, and can, we have to be a healthy, strong team in order to look after the people in this environment that we're trying to help.
No, that it definitely is not, as you say, normal. And going, like, the next couple of questions will be definitely expanding on what you've just said. So we'll go with this one first. So when there is someone that does pass away, what are the services that are able to support that particular staff member? Is it automatic, or do they have to seek that to be able to get the support that they need?
So it's not automatic. I believe before I started here, there was a formal process where once a month they had a service in one of the auditoriums here, just to when a local priest would come in and state the names of the people that died, and give people some closure, which again would be is a great idea, and something that would really help with helping in terms of letting go and formalizing and normalizing that process. They always have the support of their human resource manager, and the supports that you have on paper in terms of if you needed support for counseling, if that's something that you needed. But mostly the process is informal. One of the most amazing things that I heard at a palliative care conference in Winnipeg a couple years ago was one of the homes in rural Manitoba at the time was doing what they call a code angel. And it was, or it's probably easier to understand in terms of an honor guard. So we, over the last couple of years, when people die, we announce it overhead, and we encourage residents and staff to assemble at the front door and line the hallway on either side. And we wait for the funeral home to go down into the room, and we use a special blanket that our quilting group in Kenora has made, that we cover the body with. And then the funeral home, instead of going out the back door or the side door, goes out the front door, and goes out the front door with everyone that's there that can say goodbye. And it's something that is free, something that is simple, something that took almost no effort to organize, and had such huge impact on the staff just to say goodbye. And something that we never thought of either is their table mates, or the people that that are across the hall from that room, or just one day they're there and the next day they're not there. They see that, and they don't really talk about it because they don't know how. The psychology, I think, is fascinating depending on sort of maybe the level of dementia you have or why you're in long-term care. But there's many people here that see all these people dying around them and us looking after people that are sick and dying. And then for them to say goodbye, to help them as they're surrounded by this, I find has been huge in what we've done. And I'm so thankful that it's these little things that you pick up in each of these conferences that you go to and people talking about their experiences and things that they've done that make such a huge difference in what we're doing. But again, the psychology of just being able to say goodbye is hugely helpful for people. And it can be really, well, it is always an emotional, there's the business part of you, the healthcare part of you that, is stoic and you're doing your job and you have to do it well. And you're seeing, I see between two homes, 230 people a day that are all sort of going through the same thing. But when you have that chance to sit and reflect and say, all right, that is a husband or a wife or a grandfather or a grandmother and was a retired police chief, and you can normalize that person in terms of all the experiences and things that they had. It's sad and it's hard, and it just helps you to say goodbye. And we need to do those things too.
Because I can imagine it must give everybody, not just only staff, but the residents as well, some piece of closure and as well some acknowledgement that their person that is down the hall they don't see, and now I'm open enough to be able to talk about it, or we can be able to discuss it, as opposed to it being hush hush type of thing in that type of environment and seen as a scary thing, as opposed to that is just, I wouldn't say this is a normal process, but at least more comforting to be able to acknowledge that person. And then, because you mentioned it as well about spiritual care, so if you can just speak a little bit more about the importance of spiritual care for the person that's deemed as palliative, and as well for the family and the staff caring for them.
For sure. Well, and I'm not speaking for everyone, because whether it's just whatever that means for that person in terms of that human connection or supporting people through that. But when you have the comfort that spiritual care is able to provide. And so I'll just use, the example of, we had a Catholic priest come in yesterday for one of our patients that's approaching end of life, and the family being present, and for them to have last rites or just that prayer, that time to reflect is just so helpful in so many ways to help people in the letting go process, and doing the things that, right, I'll circle back to, what makes this so scary and so difficult and so complex for people, again, because it's the existential part of it, the part of, it's not just the person that's dying, but it's that they've always been there for you. And then it forces you to think of other people in your family and yourself. And that's probably the hardest thing. Although our focus and our effort is on the patient, so much more of it to help that person die well and in that environment where everyone feels supported. Just as equally as important is the family that's going through it, or the power of attorney or substitute decision maker, or whoever it is in that room. And that spiritual care, that person is in lots of ways already unconscious, right? But the impact that it has on the family, to have that for them is monumental. When I have the opportunity to speak to clergy or spiritual staff, and especially when we were instituting and operating our hospice, it's one of the, putting that number, that call sheet together, those numbers, and to say, how could you support us? And can we call you on a regular basis for these things? That community is so strong and supportive in that way. It's funny that I even have to say to them, would you support us with hospice, and can you come here and help with families? I mean, they're so excited to be involved in doing this. Some long-term care facilities are fortunate to have full-time clergy staff. When I worked in a tertiary care center, you had a whole spiritual care department. And when I was working in intensive care at the time, if we were going to stop care or extubate someone or turn off certain life-sustaining medications that were supporting heart rate and blood pressure, to have that spiritual care team there, I was almost a step back from my role and just let it happen because of how they could facilitate and bring them through and talk about how it's okay and this is normal and we're doing all the right things. It was amazing at the time for me to see that experience, and now I'm on the other end of it. But I feel to make this a sacred space, again, if you look at our Aboriginal community, and the system that they've had to go through and the mistrust of the system, to know that our hospice has an elder that comes between patients to sanctify it again is huge, and something that we never thought about. Those little pieces that make it okay and comfortable for people to die in, especially for the families to understand that, is integral. So we invite that team to be part of our palliative care committee, to have those communication and that talk and open dialogue with the elders to help support this community as much as we can, because it's especially not easy for our Aboriginal families that I find have a great deal of angst at end of life for all of their cultural reasons and beliefs, and they need, I find, 10 times more support at end of life in terms of spiritual care, and making that the number one priority in helping to achieve that good death, or that comfortable death, or that good feeling that they've been taken care of. Not so much the symptom management, it's that person that's there to help them in the journey from one life to the next.
Thank you for that. And so the next question we'll deal with in terms of the specialized training that's required for both the RPNs and the PSWs to work with individuals who are deemed as palliative. Are you aware, are those formal or those informal that they're provided at the long-term care facility?
So I would say a bit of both. I know that in the PSW program, in Kenora anyways, that I've been asked to speak to, whether it's the PSW group in their formal at school setting, or the RPN group at the college in their formal setting, to talk about end-of-life care and management and the role of the team and what has to happen. So I know that formally that is in everyone's program. In terms of what I then do to talk to the colleges in this aspect, is to say, we need, especially in terms of even hospice care, and what works great in a teaching hospital, which isn't there when as soon as you go to a rural or an urban setting, is the students and that team of people that are learning and going through the process and having that chance to be with someone that's dying before they start work, or having that opportunity to do those rotations. Because it's not a robust part of anyone's education. I'm fortunate that I've got a nurse practitioner student from the University of Athabasca that's with me right now, and they have to do a formal geriatric placement. And what she is going to get experience at is the death and dying piece, and looking at people in hospice and looking at people at end of life that she would not have normally in this role. So it's enlightening, and it's a part of your role especially when whether you're in family practice because you're doing family medicine, or you're an all ages family practice nurse practitioner. It's, in terms of the continuity of care, it's a piece that isn't robust. And we admit that, and that's been shown in the evidence and shown in the reviews that needs to be changed. And even in terms of specialized palliative care education, what's offered in a limited amount of medical schools. There are, though, great courses and things that you can do outside of school that can be formalized as a part of the education when you start working in different places. But for example, your LEAP training or learning essential approaches to palliative care is, and what I say to anyone that will listen that wants to take more training with palliative care, is that it's to, what ACLS is to emerge, LEAP is to palliative care in terms of your practical situations that you go over, end of life management, symptomatic management, and then the piece of the family and spiritual care, and just all of the important things that you need to learn, you need to talk about, and that you are educated on and tested on is important. And we're doing this more and more. I advocated it for our home, and we've had really good uptake, and many healthcare professionals, including PSWs, taking their LEAP training. So it seems to be as an adjunct or add-on course to what you're already doing. I find is the best thing out there that you can do to help enhance your palliative care education. I know we've got surge training, so those are the modules that staff are doing in long-term care, that, you know, there are modules on palliative care. It's just sometimes the format and learning through that when there's a video on and you're answering some questions isn't as impactful. So it's something that I find continues to grow, and something that we continue to have to promote and make better in terms of even orientating new people that are coming to work in long-term care about, you know, one of their main roles and things that's going to be probably the most difficult for them is to work with people as they're approaching end of life, and what that means. So there's a lot of at the bedside education that happens, or spontaneous education that happens as things come up. But that's something that I relished in learning in a teaching hospital, and things that I got to be a part of and got to continue to do, and that I find that I still try to continue those same things here in long-term care.
No, thank you for that. And with some of those points that we just mentioned, do you think that, in your opinion, is there enough staff, or those would be hindrance or advantages for more staff to then go into palliative care?
So without a doubt, if COVID hasn't shown exactly what long-term care is prepared for and what they can deal with and what is needed, I can't understand what is more glaringly evident than our lack of resources that we have in long-term care. It still surprises me, you know, at the beginning of the outbreak, for example, when you heard our premier talk about, you know, we figured it out. Long-term care needs more beds, they need more air conditioning, we need to make more spots so we can get more people in there. And at that time, it was like, no, that's not what we need. We need to fix the staffing ratio. You know, if you were a nurse working in a hospital, you have approximately 1 to 6 patient ratio. Well, you come into long-term care and you've got a 1 to 30 ratio. And then your focus is palliative care. And then you add hospice to the mix, and you look at the needs and the time that is required to spend with that patient and that family at end of life, and how heavy the work is in long-term care because of the acute on chronic patient management and the needs of that patient, where on your floor, maybe 90% of those people need a lift to get them mobilized and to get them changed, right? We need more staff to make that work. So making newer facilities, bigger, shinier facilities with better air conditioning, yes, that is something that we need. Right now, we need more money because of to fix our human resources crisis in long-term care, which would help immensely with the type of care that people get in the end. I mean, the burnout is exceptional for our PSW group. It's an unsafe environment for them. The amount of physical labor that they have to do, the amount of medications that have to be distributed with our nursing staff, it's a really difficult place for that. So yeah, the human resource piece is is what I was assuming and still am assuming is going to be fixed and is going to happen by the end of this crisis. But then I don't know. I don't hear those conversations anymore. And it seems that, we're quick to forget about these things, even though some expert or geriatrician is in front of CBC almost every day talking about the crisis of long-term care, and we still are just hoping, well, let's just get everyone vaccinated and that's going to make the problem go away, which is not going to make the problem go away. We need more people. We need to change the education that people are getting in here, and we need to up the specialty services that people get in long-term care, because they don't need less services, they need more services, and we have to make those working conditions optimal for people, because I don't know why we don't understand that. And I hate using this word or hate using this phrase because it's so cliche, but we're all going to die, and most of us are going to go through long-term care. And the fact that we're trying to fix problems in 2021 to make this a service, to make sure that we get all the things that we need, is something that floors me. In my role in healthcare and trying to be an advocate for this, this should be the easiest area of healthcare to find that support, to find those dollars, to help people as they transition in the most difficult part of their life when they're dying. And it's something because we are scared to talk about, because it's human nature. But the fact that we don't support it because of that, I find is another really interesting study in human nature that we continue to try to push through. It should be the red carpet treatment. It should be, you walk into long-term care and, it should be crystal and chandeliers. There should be no expense. And I'm embellishing a little bit, but in terms of helping people and the needs that we need, it shouldn't be something that we need to be fundraising for or begging for money because we're not given the same types of supports that everyone else is given in this area. So it's hugely disappointing in that way, and upsetting, because you see what happens as you're looking after these people and what the staff have to go through. So as long as we can keep pushing and we get in front of our member of parliament here and continue to push these issues. So I hope that we can still just continue to, in light of all the things that are happening, but it's still a struggle and something that we still have to advocate for and push for, is advocacy for our people that are approaching end of life.
I definitely agree with you on that, because that definitely still needs to be on the conversation piece and on the table, and still going forward to get these resolutions done. So during this pandemic with COVID-19, in terms of leveraging the technologies in long-term care, so families can partake in palliative and in hospice during this time they approach in terms of end of life, because there was the lockout, and I'm sure some facilities are still impacted by that. However, with that, what do you think that we should still be able to leverage through a lot of these virtual platforms, even if we can, due to the lockout?
So I think the lockout has forced us to use technology that we really haven't used before, and I find has enhanced a lot of things. So I'm going to just start with myself, for example, in terms of the ability to reach out to other colleagues, other specialties, and to access other education and things that normally you weren't able to access. Because for me, in our community, where I'm 2 hours or an hour from the border from Manitoba, where most of my huge committee meetings or conferences are in Toronto, that would require me to take time off work to fly to Toronto. And I've been able to, in my role, to attend exponential and actually having to say no to certain things because of how I can access education and all of these different conferences. It's been an incredible year for education in terms of this. So the spinoff then has been, because this is something that is has made it a lot easier in a lot of the things that we're doing. Our program here is going room to room with iPads, and we've encouraged families to buy iPads so that we can have those virtual visits between family and caregivers. But as much as you can make the technology robust and virtual platforms robust in long-term care, you still need the human resources part to make it operate, because you've got people in their 80s and 90s with various stage of disease that can't operate an iPad. They can't operate a telephone. So it's really tricky. It's a great idea, and it's still a great thought that we've enhanced the contact between caregivers and family, but it still needs someone to be there to facilitate it. And with, like, for example, the 116 people under this roof, it's really tricky. So they're not able to do a lot of that during the day because of how much it needs to make it work. It would be interesting to see if it would be a part of this Bill 3, the platform that's coming forward in terms of what the priority of our government is in terms of enhancing palliative care, if that's a piece that needs to be integrated into that to help us with that. I mean, I think it would make a huge difference for my palliative and nurse practitioner that's working in the community right now, that based on her organization that she works for has to work from home. So she is doing 100% of her palliative care visits on the phone, which is immensely or hugely difficult. Maybe in terms of, if you are deemed palliative and you have got home care coming to you, does that mean that we also support you with the technology, and we support you with those platforms, and people get those iPads so they can communicate better with family, and maybe it helps with that assessment piece and talking to people at end of life. How do you enhance virtual care and long-term care, where we've got the lowest budget of anyone in healthcare, to add something as robust as this? I think the sky's the limit, and I think there's endless opportunity with this, and I'm really excited about it. But it's something that we just continue to invest in and put money in. And again, it's not easy. It doesn't take away that person to make that work. We still need the human resources to make the technology be able to function and operate, unless every new build and every new room comes with all of this technology that's built into it already. But that would be quite a facility.
Definitely it would be. And we'll only see how things will still continue as this pandemic continues onwards, and see what the future will bring with what technologies will be supported in long-term care sector. Now, with the passing of Bill 3, the Compassionate Care Act, do you see that as being as an enhancement to what is already existing for long-term care? Because that's supposed to allow for everyone to have access to palliative care.
So I'm always going to look at this as the glass half full, and I'm thrilled that they've passed this act. I'm perplexed on why we have to pass an act like this in 2021. But again, this is wonderful, and I have to commend the government for doing this and putting this forward. I mean, how I think, it's one thing to implement or state that, just for example, with how heavy the policies, procedures, the technicalities of working in long-term care and how it's governed, it's so heavy that way. So what I'm hoping that Bill 3 doesn't do is just, again, add another layer of things that long-term care is expected or has to do. One of the things that I think Bill 3 could be an immense part of is changing the education out there and supporting in terms of the rotations that whether that's in medicine or nursing or the PSW group, what's expected in that education, how it's formalized, and the time that it's given, I think would be a missed opportunity if that bill didn't affect what we're doing in all of our schools in this province, and hopefully in Canada. But again, I called, I have a really good relationship with the school, with the University of Manitoba. And I called one of the professors yesterday and I said, so where is it in the curriculum that you're discussing MAID? And he said, so that's a good point. Why don't I pencil you in and you can come and do a talk on MAID? And I'm like, exactly. So these are one of the things that, how do you formally approach each of these schools to say, what are you doing and how are you doing this? But it's another thing when the government is saying, this is a priority and this is what we have to do and we have to change it. And so I think will happen faster because of it. If and part of that mandate is looking at education, but I think that's probably one of the biggest things that they could do to enhance that or to push that, to make that better. I don't want to speak for my physician colleagues, but it's not easy for the things that they are doing in terms of the business of being in family practice and hiring staff and having overhead and seeing patients in terms of the amount of patients that they're trying to do and what they're doing to trying to run a business is what people aren't prepared for when they graduate from medical school. And when the money around looking after hospice and end-of-life patients in palliative care isn't the same as looking after other people, it has an effect, right? So I could say, well, this is fantastic. This is another great role for nurse practitioners, but there are discrepancies in the system. And I don't know why it's valued differently and why we put a price on what people can bill for or the care that people would get, but it's definitely a barrier. It's not easy. You can't run and see 10 end-of-life patients in an hour and be able to bill for that. It takes time. It takes conscious effort to be with that person, and a palliative care visit isn't easy. So I find it's a barrier because it takes away for and is difficult for different providers to do that, unless that is their passion, right? So now we're talking about two very different things, right? Still, you look at the ability for, and again, I'm talking about the business of healthcare, I can't go leave my facility and see people in the community to provide that palliative care or those MAID services because it's something I have to volunteer for in my role. NPs can't bill. So again, there's a huge barrier where there's a need that NPs would be willing to see people outside of the context of hospital, clinic, and long-term care, but we don't have the ability to do it. So those are big things that could help, especially in places that like rural Ontario or Northern Ontario and all of these things. We have to be creative to make sure we get all these people that access, and hopefully that bill can push those things forward and open up new opportunities for people to want to deliver palliative care and get more involved in palliative care because it's supported and because there's that avenue to do it. Right now, there's not that avenue, or the avenue that exists isn't supported very well. Right? Ideally, everyone should be able to die at home or die where they want to die, right? And it's, you just look again at what we can provide or help people with their home care services, if that's something that, we could fix, just that piece alone would make a immense difference. So again, it's really tricky. I'm really excited that we've got hospice up and running in Kenora, and really happy that we can do this in long-term care and make it happen. But it shouldn't be in long-term care. It shouldn't be at the hospital. It should be in that person's home or in its own community setting and run by the community to make that work. And hopefully that that bill can also address where funding goes and how it's supported in that way, because we know that it's not. It's a drop in the bucket in terms of what the services that we're getting from the ministry. I mean, for example, and I'll stop talking, $105,000 a year is given to us to operate a hospice bed. Well, that is fantastic. But to operate a bed, even to staff a bed by one RPN around the clock, 365 days a year, costs about $350,000 to hire one RPN to look after a hospice patient, right? And when we've got a 30-to-1 ratio, it doesn't take into account the cleaning services, the food, the bed space, everything else it takes to, we're not even talking about adding a PSW to the group or the provider, the NP or GP that's looking after that patient. So how do we make it work? How do we have all that specialized care and give all those people those services that they need and that they deserve at end of life when we don't fund it? That's something that's beyond my pay scale. It's something I do not understand, because we will all go through this process in what we are funding right now and how we are staffing it right now. So we need to fix it for the people that are going through it and for our families. But as selfish as I mean this, we need to fix it for us right now. We're going to go through this process. I don't know why it's not a seamless machine right now.
I couldn't agree with you more, because honestly, I hope that with this bill being passed, that it's part of the discussion for the whole reimaging of long-term care. So I really do hope, because it really needs to be on there. And you made some other points about MAID, which is the medically assisted in dying, in the fact that you cannot bill OHIP for it, and you cannot charge for MAID services outside of your employment. So how does that get then billed into, let's say, made into your services? Does it have to be part of your job description in order for you to be able to service that?
So that's a really good question. And so I'll speak about my community just briefly. So there is some really great colleagues that I've been able to learn from in terms of medical assistance in dying, and the process and just to how I've learned from them and what it takes to do this. It was one of the heaviest things for sure in my career that I've done, and one of the things that I feel is one of the most important part of my jobs now, as I can honor that person and respect that person when death is in their imminent future, and helping them in terms of it being, which I believe, which might be a scandalous thing to say, an extension of palliative care. But when I see people that are approaching end of life that can't swallow anymore or can't breathe, and are seeing themselves pass away, and that suffering that they're going through, that we are forcing them to articulate to us to see if they would be a candidate to have a procedure like this. It seems weird. But it's for them to empower people to have control of what is imminent and what is inevitable, and for the living funerals that have developed because of it, that I've been a part of people saying goodbye to their families, and families, instead of getting up at a funeral and saying the things that they would want to say about this person, that they're doing it right in front of them at that moment when they've got their kids in the bed, the dogs in the bed, one of the craziest things that I've ever been a part of was the daughter was in the patient's bed before I was going to provide MAID, and she had that stupid little storybook the night before Christmas where you can record the kids' voices on. She did that with the grandkids and did that with the person as I was doing the procedure. It was so beautiful. It was so heavy. And it comes back to the point of, this is why we need psychology, and this is why we need this help, because of how intense it is. But so my role, that I'm able to provide and do this, and am compensated for it. And I hate using these words because it sounds so selfish, but when people need it in long-term care and have the capacity and can do it, I do this for people in long-term care. In the community, to help the community, I was going after hours and on weekends to help people have MAID at home. And so why am I doing this? Well, because it's not easy to do MAID in someone's house. it's not a quick procedure. It's not something that takes just a couple minutes out of your time to do it in the thoughtful way of all of the things that is required, when essentially maybe it's you with another nurse or another nurse practitioner, not a robust team of people that are around you. It's not easy. And I understand why my colleagues in the community struggle with doing MAID in people's homes, because, well, when you're doing it in the hospital, and even when I'm doing it in long-term care, I'm surrounded by a team of professionals. There's, whether I'm in the room or I'm not in the room, or I've done the procedure or I haven't done the procedure, there's this people that they're already around them. The PSW that's speaking and helping with the family, it's the nurses, and plus or minus, if you're in the hospital, social work that's there. You need so many people to be there to make it happen and to make it work in that thoughtful process. And when you're in someone's home, it is different, right? You are mostly doing all of these roles by yourself, and it takes time. And so again, it's more desirable for MAID providers to have this done under these roofs where you have all these resources. But I'm passionate about palliative care, and I'm passionate about MAID. And if they wanted it at home, they should be able to have it at home. So I was just making that my mandate, that I was going to do this in this community and help do that. But over the past couple of years, I've burnt out. It's not easy. And what I'm doing is band-aiding the system, doing this on my own time, to honor and respect people, to make it work. But there's a gap in the system that I haven't improved. And so I continue to try to work with the community to try to support that and help people to die at home. But until they're going to also allow NPs to bill, or make the billing process different, or make the team that is able to accompany MAID providers to those homes to do that well and thoughtfully, needs to change. I feel like it's done mostly because it's an emergency situation of people that possibly could be losing capacity, and to have all these people set up, nurses to put in IVs, pharmacy to get those medications in a timely fashion, to have the psychology there that's present, just everything that's involved. It's so complex that I believe is what makes most people not want to be involved in medical assistance and dying, or be a part of it. You know, you could be a conscientious objector for many reasons, but just that piece alone in terms of trying to pull it off and what's available to you is, you know, it's really tricky. I never thought in my career that this would be such a big part of my role, and something that I would have to advocate for. But again, if this is what is most important and what I can do to improve the system, shed light on the system and make things better, then it's the things that help me sleep the best at night in terms of what I'm able to do in my role.
So thank you for that, Micheal, because now with MAID, is that one of those things where it is, especially in long-term care, is that one of the processes that are defined before for everyone? So that is, let's say, on the electronic health record. So people would know that would be active, or they can take advantage of that.
So that's a little bit tricky, because It's something that, you know, lots of hospitals and homes don't want to advertise because of their law. Have you ever thought about, you know, we can't really promote, which again is just, it seems odd, but I find in long-term care, it's not so complex, because we know right away the people that are coming in here that have that capacity, because it's not as often. There's not many people that are eligible for MAID based on the current law that come in here. And those that are, families, for the most part, based on how much attention and how mainstream MAID is becoming and how it's in the media, are usually quick to approach me to say, we've talked about this, or this was their opinion at the time, or it does come up usually, or it can come up with a change of condition when families are talking about it. Families, I find, are wanting to talk about it anyways because they see this advanced dementia, and they say they would have wanted this and talked about this beforehand, but now they're not eligible, right? Is the answer that I get. And it's something that, part of that education piece that we have to give to people just in terms of that process. But formally, it's not a checkbox for us that we have in our admissions process, that is something that we've discussed and that we've talked about. But because I don't know thoughtfully the best place to have that. It's so overwhelming when people are going from community or hospital to long-term care, and on the admissions process, honest to God, when sometimes maybe the most important thing the family's trying to figure out is their cable package, that also now you're talking about, have we talked about medical assistance in dying? It's just so much to deal with. So, but it is something that it does get teased out within the first few weeks to few months of people being in long-term care. But so often for so many of these things, it's just timing and doing it in the most thoughtful process, sometimes of just when those opportunities come up. We used to overload people in their first care conference or their initial care conference at 3 months. And, I would talk about frailty and the PPS score, the surprise question, and just all of those things. And, people are just, accepting the fact that their loved one is stable in long-term care and they're able to visit them and things are working. And it's not the time to start talking about death and dying. It's always a good time, and it's always good to bring up those conversations, but sometimes you just have to be really respectful and tasteful when you have them and when you bring them up and when people are ready to have them. And that's a constantly moving target. And that's what I was talking about other long-term care facilities last week was, they were saying to me, well, we've got this box and we need to check it off. We need to know where we need to put this box. And I'm like, excellent point. But in order for people to accept that box it's got to move all over the place. It's not something that just goes at this time, because it can be really offensive to bring up death and dying with, different families, depending on the timing of things. And so you just have to do it as carefully and as compassionately as you can. If that makes sense.
No, definitely. That definitely makes sense. Absolutely. And then with the participatory action research, the PAR method that's used, would you be able to indicate like what the benefits would be and the lessons learned from using this type of a method?
So in terms of eliciting social change, or that experience that's learned with this method from engaging the staff that are going through this work and observing what they're doing and asking them for their input in terms of what's most beneficial or what would be most helpful. For example, the example that you used in the question in terms of the PSW role, and how task orientated it is and how we use them. Or in terms of their job description and what they're doing in long-term care and what they're not doing in long-term care. So maybe it's easiest to answer this question in terms of and I won't just use the PSW, but I'll just use the healthcare staff and long-term care in general. What we're not doing is the things that aren't intuitive or don't seem intuitive in terms of the dementia care piece, the piece that just involves the non-pharmacological piece of working with people and learning about those people and doing those activities that help with those, the day-to-day boredom that happens in long-term care, the agitation and aggression that can happen with dementia, and the things that the non-pharmacological interventions that can help people to promote and give them the best quality of life. And it's the same at end-of-life care. Our PSWs know that, right? They're turning patients, they're doing mouth care, they're toileting, or they're changing people, and they're in and out of that room, heads down, doing that task, and coming back out, right? Where there's a missed opportunity. there's a missed opportunity for PSWs and for the RPNs that are going in there to do these tasks or to give these medications, to have, those thoughtful conversations with people to say, hey, how are you doing? And how can I help you through this? And what can make this better for you? And it's the social interaction part, the part that isn't provided in any task that they would do, the humanistic part that we're not doing. And it's probably the hardest piece to maybe teach or to incorporate in that type of education, because what does it look like and what does it mean? And I didn't sign up for this. I'm not here to help people when they're dying or when people have, dementia, to help them in this process of, of when they're aggressive or when they're agitated. My job is to get them in the tub and get them out of the tub. And I need someone to give me a medication because they're yelling at me or they're having pain or something's different. We just have to get away from using medication to manage people. And it goes right back to the human resources aspect of that. Our gaze is to the ground, our boots are to the ground. We're running to do those tasks because in long-term care, they've got to get 30 people up before 8 o'clock in the morning because the ministry mandates that they're in the dining room at a certain time and that we give them all these medications at a certain time. And so what happens is we've got people that suffer because of that, because we're doing things to people that they don't want to experience that quickly. Maybe the time or the process it would take to get someone thoughtfully out of bed that has dementia, that doesn't understand what's going on, and the medications we use to try to sedate people to wake them up so we can get them dressed, so we can get them fed when we're trying to respect and honor the person and what's happening at the end of their life. It's a real machine of moving people through an institution because it's institutionalized care. And this is where we fail the whole system. So in terms of different models, and I'll just use butterfly care, for example, that's out there and being used in different places. But that thoughtful process of taking the institution out of care and doing things, learning truly about these people and what they need at these times, and helping them in the most robust non-pharmacological ways that we can is what we need to do to give people better quality. And so it's difficult because it takes time, it takes huge investment, it takes a lot of support, and it's easy to say, this is your job, this is what you do. Just try to flip that or spin that takes a lot of effort, but with advocacy and with trying to, really it is the best evidence thing that we could do to support people. It's just a matter of having the right people on your team. And I feel like we've got that here, which is really lucky. And I wish we could do it right now or yesterday, but it's a process that is slow to unfold, but is something that as long as you're passionate about those things and really invested in the people that you're working with, in wanting them to enjoy work and to give 100% of what they can do in this job, it can't be something that we can't create a hierarchical system here. We can't not use different people in the healthcare system in terms of accessing the robust information that they have on what works and what doesn't and what's helpful, and why we, essentially eliminate entire groups of healthcare individuals on what would work best. What should we do in this situation, and how could we make this better? Again, it's all about how we communicate and how we support that team. And there's endless ways of doing that, but feedback in terms of everyone that's on that team and in that role is probably the most important thing, the most respectful thing, the most holistic thing, and it's free. And there's tons of benefit, and it probably doesn't have to, change much in terms of what our role is. It's just a matter of teaching and being present and trying to just encapsulate those things in all of the care that we do. I wish it's something that, just provincially or nationally, this is what care meant in long-term care, and this is how we went about it, and it was scripted, and this is what it meant, and you got the same consistent care no matter where you went. But that is so far from the truth that it's overwhelming. And it seems like every time we try to improve working conditions or palliative care, end-of-life care, or dementia care and long-term care, it's like a grassroots movement, again, because it's something that's not funded, poorly human resourced, and the education, right, for the amount of work and responsibility that PSWs have to go through. I can't remember, is it a 3-month course?
It's depending on if they take it privately. It could be a 6-month course for them, up to 2 years, depending on where they take it.
Right. So in terms of providing 95% of the workload of what they're doing in long-term care, right? It's just, there's so much more that we can invest in this group, because they do so much good work and so much of the work. So how do we support each other when we're doing it? Again, hopefully this bill will shed some light on those things in terms of supporting everyone in long-term care.
No, thank you so much for that. And I do hope that with the Bill 3, the Compassionate Care Act, as well as with all of the talk that's going on with long-term care, that all of this is looked at to kind of re-image it, remodel it, so we have a much better understanding going forward. And lastly, I just wanted to ask you, in terms of with using as well nurse practitioners more so in long-term care, because right now different regions of the province have different ways in which to use nurse practitioners. Some are dispatched from hospitals, and you're working at 2 different facilities. So how would you see that, going forward, as to how that should possibly be?
Well, in terms of the role that I have in long-term care and what I've been able to do, or the impact that I've had here, I first want to say that, so I've got an amazing medical director in Dr. Micheal Thomas, who is so conscientious of what she does and supportive in what she does. And she said to me soon after working here was, Mike, you've really made a difference in what we're able to provide here in long-term care. And I said, what I've seen isn't, I said, thank you. I said, but I don't think it's me. I said, I think it's just that in long-term care, we've created a position where we've got a provider that works Monday to Friday, 9 to 5. And I said, in the role typically, and how long-term care works in Ontario is like northern nursing stations. It's nursing, working on the floors, identifying an issue, calling a doc at home or on evenings and weekends and saying, I've got a problem. I think the problem is this. They get an order for a medication, and hopefully it solves the problem, right? So having someone in the building, whether that's a GP or whether that's an NP, makes a huge difference on the management of patients that are happening at that time, because we can assess and figure out what's going on in the building. So because of that, I'm able to deprescribe or reduce a lot of medication, unnecessary medication that people are on in long-term care, because I've got the time where I can do that. I can and have decreased hospital transfer immensely. So in terms of, or preventing inappropriate hospitalization, because of being able to have those conversations with family and talking about goals of care and risk benefit of certain treatments. And, I'm fortunate enough, because I worked in a tertiary emergency department for so long, to take people through so this is what this diagnostic test is going to show us. And these are the 3 probably best possibilities or 3 worst possibilities. And based on what that information means, how is it going to change our management? And is this mean that now we are going to start chemoradiation when we're 99 years old, or that we're going to consult a neurosurgeon because you're going to have some type of invasive surgery, or we're going to do, we're going to consider intensive care admission for 3 to 5 days of intubation, because this is possibly going to extend their life but not change their quality of life. Those conversations are really difficult to have, but because I'm here, I'm able to have those conversations. And I think that's why I make an impact on preventing hospital transfer. it's the acute on chronic disease management. I think that's the biggest thing. So everyone here essentially, in terms of the trajectory, that's always sort of on a downward slope, but depending on what's going on in terms of all of the things that can happen in terms of infectious disease, pneumonias, falls, trauma in relation to falls, pain management, the things that I can do at the time makes a huge difference in addressing people's needs thoughtfully, and fixing and or alleviating a lot of symptoms immediately. That gives that care to the residents that need it to the most, but to the families that see that that's happening at that moment versus waiting, for the nurse to call the physician or waiting for the physician to come in on their scheduled day when they can come in. There's so many other variables to that, but the most important part of me being in long-term care is my effect on palliative care. And I had no idea what to expect or what I was coming into in long-term care. And there's so many people here doing such great work in palliative care, but to help formalize a process, to help teach about palliative care, to access early palliative care and to make changes earlier and not later and not in crisis, and to help people go through that and preparing for the future, just the psychology around that I didn't think would be part of my role ever, or something that I would have to learn and get really good at. But I would say that's my biggest role in here is, preventing death in hospital, having those discussions around it and helping people die well. And it's an honor for me to do that. And it's not easy, but I have the time where I can do that. I think it's essential that I don't know how long-term care runs without having a dedicated provider in the building for all of the needs and all of the things that happen in here. So, it should be the mandate of every home in the province that has either that position that's for our physician colleagues and or for NPs and or a combination of those things, because there's just so many things that we can do to augment the system that actually saves the system, that improves the system, that benefits the system. And with some minor tweaks on helping with the human resource piece makes that system so much more robust and helps to achieve those things. I don't think it's that complicated, but for sure it needs to be supported in different ways to make it work well. So again, when I get to stand up at a conference or in front of a committee, or when I'm teaching again and I'm in front of my master's students, and I can talk about your role as a nurse practitioner and what your impact is in long-term care. I thought I had big impact in Emerge, but not like I do working in long-term care. And I would never change that. And that's the part I thought, long-term care, this is going to be great. It's going to be a stepping stone for me. I'll get my experience and it'll help me to do, help my experience and learn before I, do my next thing. But I am hooked. I am in so deep that there's so many things that need to be augmented and helped and fixed and supported, that this is my passion. This is what I will do, and hopefully improve the system enough that I'm able to reap those rewards, if I can say that.
No, absolutely. No, thank you so much for that. And I'm really grateful that you're able to come on and speak onto the Long-Term Care Chronicles about palliative care and end of life. I think we've learned a lot of what you've indicated, what the role of the nurse practitioner would be with that. So again, I just want to thank you so much, Micheal, for your time, for coming on. Thank you.
Thank you so much. It's an honor.
You're welcome.